Pediatric anesthesia. I invite the chairpersons, Dr. Raghavendra B.S., Associate Professor, Department of Anesthesiology, BMCRI, Dr. Raghavendra Bosle, Associate Professor, Department of Anesthesiology at KIMS Hubli, EC member ISACON Karnataka, and Dr. Padmanabha Kaimer, Associate Professor, Department of Anesthesiology, KMC Mangalore, to kindly take their seats on the stage. Our first speaker is Dr. C.R. Chandrasekhar, presenting on the art and science of pediatric regional anesthesia. Dr. C.R. Chandrasekhar is a consultant anesthesiologist with over 2 decades of experience based in Bangalore. Throughout his career, he has specialized in pediatric anesthesia, pain management, and pediatric advanced life support, authored a chapter on challenges in pediatric laparoscopy in a textbook of pediatric anesthesiology. He holds memberships in the Indian Society of Anesthesiologists, All India Difficult Airway Association, and Indian Association of Pediatric Anesthesiology. Dr. Chandrasekhar consults at Sagar Hospitals in Jayanagar, Bangalore, and is known for his dedication to safe perioperative care for children and complex procedures. To understand the basics of regional anesthesia in our tiniest patients, we welcome Dr. C.R. Chandrasekhar.
Good morning, everybody. Being an alumni of Father Muller Medical College, I'm very proud to be talking in Dr. Koshi's auditorium. I'm thankful to Father Muller Medical College for having given me an opportunity for this. Without wasting much time, we'll start with the talk of the day. My topic of discussion today would be tiny patients, big block, pediatric regional anesthesia. Traditionally, pediatric anesthesia and pediatric pain management was the most neglected or little understood topic, because any child coming for surgery scared of pain. And long back, there is a myth. Children do not have pain, or they are unable to express pain, or they do not understand pain, or we have not understood the child as such. So, any pain management or any regional anesthesia procedures always goes with general anesthesia or deep sedation. So, because you cannot give a regional block in a child who is awake, whereas in adult, we can go ahead and do it of the procedures. Even though first pediatric spinal was given by Augustus Baer in 1898 for a child with a thigh tumor, it didn't go well, because anyhow they were giving general anesthesia, so they didn't concentrate much on the regional anesthesia in children. Even though they are the excellent alternative GA in children, they have done thoracic surgeries, pneumonectomy, lobectomy by Bainbridge, Pernetal, Berkovich, and so on. In 1970s, things started changing. So we do understand that children have pain, but nervous system is immature. Then they started adding it is a complementary to general anesthesia. So there was no only sole regional anesthesia in children, or partly because of the modern anesthetics. See, we had ether, halothane, sevoflurane, isoflurane, so on. So advanced monitoring system was there. So people were concentrating more on general anesthetics, opioid for pain management. It was not popular until 1984, when the preterm neonates were anesthetized for her obstructed hernia, laparotomy, and so on, small procedures, they used to go in for what is known as the post-apnea. So then the started thinking, why you ventilate the child for a small procedure? There was renewed interest. So then they started thinking of coming back to regional anesthesia in children. Regional anesthesia, you are all aware, it is a versatile tool in the armamentarium of anesthesiologist. Of course, benefits are enormous. Reduce opioid consumption, instead post-operative nausea and vomiting, reduce post-op pain scores, and reduce incidence of respiratory complication, so on and so many. I have not listed this one. Coming to the what are the technique of regional anesthesia in children. It can be like in any adult, it can be central or it can be peripheral. We started almost 20 years here back when we started anesthesia. It was mainly the landmark technique. For example, we used to give supraclavicular brachial plexus block. We used to identify the landmark. Then we used to put the needle, ask the patient, shock laga kya. So he says, yeah, I'm getting some sensation. So we used to give the supraclavicular brachial plexus for procedures of the upper lip. Then came a nerve stimulator. So we used to identify the nerve structures by contraction of the particular segmental finger movement or so on. For example, a finger movement of posterior card will cause supination, pronation of the hand. So we were thinking, oh, we have hit the posterior card, so we were able to do the procedure. Recently, ultrasound has come into vogue, so we are able to identify what are all the structures, where the vessel is, where the nerve is, where when we are talking about the supraclavicular, where the pleura or vital organs are there. Of course, you are all aware what ultrasound has given to us. It is a good tool, improves the success rate, prolongs the block duration, because we are injecting the drugs very close to this one. Time is reduced, needle passes are reduced. High frequency linear probes are used for superficial blocks. For deeper, low frequency curvilinear probe. Now, you need not have to search where is the nerve, where is the artery. GE has come out with an ultrasound machine with AI technology introduced. You identify, you want to mark the nerves, it will identify the nerves. Machine costs you approximately around 45 lakhs. So you want to supraclavicular brachial plexus block, it identifies the nerves, inject local anesthetics in and around, your job is done. You need not have to search where the nerves are, where are the nerves are. Is regional anesthesia in children safe? Yes, there are so many American societies they have studied. Pediatric Anesthesia Society has put a little graph. French society also says the incidence of complication in children are less. The overall incidence of related complication was 0.9 out of 1,000. But crux is, children are given regional anesthesia along with deep sedation or general anesthesia. So, six-fold increase in the complication rate for central versus peripheral technique was demonstrated by the French group, which should further persuade pediatric anesthesiologists to modify their practice towards more peripheral, go peripherally rather than going centrally. The complication rate was 4 times higher in the children under 6 months of age. When you perform a lumbar epidural or a nerve block under sedation or under anesthesia in 6 months, it is 6 times more problematic. So you need a trained pediatric anesthesiologist to overcome that. When we are talking about the children, there are different categories: neonates, infants, older children. What are the unique considerations you have to go in for? Of course, there are risks associated with general anesthesia, so you are going for regional anesthesia. To give a regional anesthesia, you have to be perfect with your anatomy and physiology in neonates and infants. So what are the differences? Even though we are talking about the peripheral nerve blocks in children, there are certain procedures which is difficult to replace when compared to peripheral nerve blocks in adults. The spinal cord ends at L3, L4. So when we are giving a spinal anesthetic in an infant, it should be below this. L5, S1 is the option. So it should be performed at this to avoid injection into the spinal cord. Dura ends at S3, S4 in neonates, S2 in infants. When you are giving a caudal epidural in a child, be careful, you are giving at S4, S5. If the needle goes inside, it can become a spinal anesthetic. So because you are giving a large volumes of caudal drugs, so it can become total spinal. Vertebrae, they are cartilaginous in structure, soft. If you do not sense, you can inject into the vertebral bodies, it can become intraosseous, is as good as a intravenous injection. Incomplete ossification, easy for ultrasound to identify the structures. Epidural space, it is fluid in nature, so that large volume of local anesthetics can go up and you can pass the catheter very easily, even up to thoracic level. Meninges are highly vascular, causes faster absorption. Of course, cerebral fluid volume is 4 ml in infants and 2 ml in adults. So shorter duration of action, you need larger volume of the drug to produce the same effect as in adults. This is the pictorial representation. Coming to the physiological changes, we thought children doesn't have pain. So because immature sympathetic nervous system, there is limp hypotension. When you give spinal anesthetic, children, there is no hypotension. Also contributing factor would be the large volume of blood will be flowing to the abdomen, head and neck. So leg part of it takes less blood flow, so there is nothing. Immature hepatic function, so toxicity will be very high when you give large doses. Local anesthesia induced systemic toxicity will be well known. Reduced concentration of alpha-1 glucuronide proteins, increased free drug is available, toxicity can occur. Of course, other factors which helps in likely to cause more toxicity than. Of course, drugs, same as in adults, bupivacaine, ropivacaine, only lidocaine with adrenaline is 7.5 ml per 7 ml per kg body weight. Additives, it all depends on the individual institution. We practice fentanyl for epidural. Of course, there are indications, contraindications, which all the textbooks gives. But one thing in children is the abnormality of the spinal cord. See, this is because you thought of giving caudal, there is a spinal abnormality, so you will not be able to give. See, unlike in adults where you can insert a. So coming to the central system, see, I will be touching about spinal in a neonate. Subarachnoid block, you have to use a needle with a stellate. Hypodermic needle should not be used because this can carry the structures inside and can cause the intradermal impact. Bupivacaine dosage is 2.6 milligram per kg. It comes to around 0.12 ml. So, of course, now lidocaine is not available. This is the spinal anesthetic being performed in a newborn child. You can see it is the lateral position. One can give it in supine position also. You can see the hypotonia of the lower limbs. You can perform the regional anesthesia technique is followed and obstructive hernia is being repaired. Of course, we are talking about the premature apneas. This is how the child will have apnea. If respiratory is low, saturation will be very less. Coming to briefly about caudal, we are all practicing caudal epidural for various reasons. Just one thing is, it is a single shot. To make it a continuous, either one can put in a catheter, or you can even insert our cannula and you can give continuously. Only thing which worries is it is very close to the anal opening, so one has to be very careful about this is how the sonoanatomy of the caudal looks. Why not peripheral? See, long since we are practicing peripheral. For hernia, ilioinguinal, iliohypogastric. We have been practiced, but there are complications which are reported, such as colonic perforation, local anesthesia-induced motor blockage. So, as and when chances are available, please go in for a USG guided rather than going for a blind approach. Coming lower limbs, we have got spinal and epidural, whereas upper limb, we don't have such facility, so we get into this one. Multiple approaches for a brachial plexus block. Interscalene block is often used in adults, but very less used in children because one is neck is very short, it is difficult to position, and structures are very close. So if you give a slightly large volumes, it can affect the other structures. I'll show you in the diagram. Who are all attended the ultrasound workshop yesterday? The experts must have shown, this is how the interscalene looks like. So in the workshop, it looks very easy. They come, they give the local anesthetics, fine. When you want to practice, where are the structures? There is one app called ANSO, A-N-S-O, ANSO, Sonoanatomy, which is a mobile app. This is taken from that. See, this is the interscalene. See, look at this. C5-6 roots. This is the artery, this is the vein. It shows you can have these structures in your hand. See, this is how the needle comes. This is the musculocutaneous nerve. Here is the phrenic nerve. So if you give slightly more quantity of drug, so you can have hemidiaphragmatic paralysis. These are the carotids. If you go down, you are injecting into the carotids, vertebral artery. Here is the channel for CSF. So it can get into spinal. So vertebral artery, spinal, all these things are complications which can be expected in this. Of course, this is the diagrammatic representation of that. We were giving blindly scalenus medius anterior, this thing. In the group, we used to give a lot of drugs, and it used to act 25 years back. We have practiced this, but with technology available, one can go in for higher resolution imaging. And of course, supraclavicular buck, we are all aware it compasses below, involving humerus and below. It fell out because risk of damaging the pleural. This is how it looks like, this thing. This is the carotid. these are the structures. I'll go to the next slide, then you'll see. See, this is how, see, pleura, artery, vein. So, please have this app downloaded in your mobile so that it is easy when you are learning curve, when you are practicing. This is the lateral approach, infraclavicular approach for the brachial plexus block. It covers it is also called costocoracoid process. See, you can use the landmark technique 1.5 centimeters down and medial, go and inject. Usually in adults we block the posterior cord. In children, you need not have to go to this thing, even lateral cord is sufficient enough because tissues are loosely attached so that it acts on all the three structures. See, this is the axillary artery vein, lateral cord, posterior cord and medial cord. So, when you take this app and see in the ultrasound, you can directly use this. See, this is how the needle comes. So, this is your blocks are sure to act. Axillary is the cheapest and the most common approach we have. Cut is the easiest of the all. One can give even blindly because on either side of the axillary artery, we used to put 2 needles, inject, and one transarterial aspirate. If there are no blood, we used to give because posterior cord used to be posterior. So this is the sonoanatomy. This is the ulnar, radial. Here this is the median. Musculocutaneous nerve escapes through this. So that's why when you are using axillary, try to block this now also. Complications, as Madam has described, even though our patient doesn't take hematoma, infection, intravascular injection, intraneural injection, pneumothorax in few cases, and so on. Next, commonest would be abdominal surgeries. Nowadays, laparoscopy has gained importance. So, tap block is the commonest this thing. Please use the ultrasound as a modality of pain management. Blind method of identifying the tap block, giving a tap block using pop technique, as there are case reports of damaging the vessels, damaging the liver, injuring the intestine and other things. So, external oblique, internal oblique, transverse abdominis, go inject here 15 ml on each side and you can get it. See, this is how, even if you do not have an ultrasound, you can ask the surgeon when they are putting the trocar, this is the tap block given through through laparoscopy. Coming to lower limb, commonest children injure the foot and other things. Popliteal fossa block is the commonest, which we give it to them. Patient positioned on lateral position, like as if in caudal position. The sciatic nerve divides into common peroneal and tibial nerve at the knee. So identify the fossa. This is how a sonoanatomy at the looks like. Common peroneal and tibial nerve. Peroneal nerve is lateral, tibial nerve is medial. This is the needle of injection. Be careful not to inject into this one because it has case reports of foot drop have been reported. Coming to femoral nerve, which is easier and more common, which is block, can be used for, especially in patients where you take a skin graft, femoral nerve and anterior cutaneous nerve of the thigh. So vein, artery, nerve, van is the one, ultrasonic curve. Even though this is the sheath, it is just slightly outside the sheath. So one can identify the femoral nerve through ultrasound and give sufficient quantity of. Coming to this thing, when you give local anesthetics, what can happen to? See, last, local anesthesia induced systemic toxicity. So we're all call for help, stop injection, multidisciplinary approach, all these things are there. Of course, children with sedation or tube are there. Increase FiO2, adequate breathing, check for if the heart rate, cardiac event has taken, go ahead with this thing. If the seizure is present, unlike in adults where they complain of peripheral numbness, seizures, and then cardiac listen, here there is, all these things are masked. So give benzodiazepine, start intralipid emulsions, bolus of 1.5 ml per kg over 1 minute, followed by infusion at 15 ml per kg per hour. After 5 minutes, if the severe stability is not achieved or if it deteriorates, 2 more boluses can be given at 5 minutes apart. Double the infusion at 30 ml per hour. Take care of other systemic involvement, cardiac and other things. See, next thing would be thoracoscopy, because most of the centers started doing thoracoscopy. When if you don't have any testing, this is how the intercostal block can be, after this is one lung ventilation, intercostal block can be given like vein, artery, nerve at the lower border of this thing. We inject about 2 to 3 ml in each segment at 4 to 5 segments wherever they are put in a trocar, and you can do the procedures. What happens? Tab block we have talked about, central we have talked about, peripheral is, if the abdomen is distended like this is a case of hepatoma, it is difficult for us to identify the anterior abdominal wall layers. So we may have to go back to central, like epidural for postoperative pain management. So in children, both central and peripheral nerve blocks, or central neuroaxial blockade and peripheral neuroaxial blockade, coexist together. It is safe, economical, brings satisfaction to the family, reliable, especially when you are using ultrasound. Small quantity, good target. Now with AI has come, it is still more easier for you to go and give peripheral nerve blocks. It gives early recovery after surgery. So ERAS is excellent. Less opioids, you can discharge the patient on the same day. You watch for the movements. If the motor blockade has not come, please do not discharge. If partial motor, partial sensory is there, one can send the child back to home and ask them to come back if there is any. Parental satisfaction is excellent. Last is better done with modern drugs and monitoring system. Thank you. These are the references.
Thank you, sir. Thank you for the wonderful explanation about the regional anesthesia and pediatrics. We will take up the questions after the session.